Welcome. I'm here with Dr. Daya. We're going to jump into some of the protocol updates. So, Mo, the first one I want to talk about is the altered mental status protocol and some changes that we've got coming up there.
Yeah, so the main thing we did in the altered mental status protocol is we added a precaution, particularly when people who are hypoglycemic and you reverse them either with oral dextrose or IV dextrose. We've had one recent case in which a patient was allowed to refuse without online consultation, and then the person had recurrent hypoglycemia. So what we really want you to do is think through the causes of hypoglycemia. So if the person is hypoglycemic, they're diabetic, you reverse them, they wake up, spend some time thinking about why it happened. Was it a clear explanation? Are they now back to normal? Are they able to eat? And has their sugar control recently been normal? And more importantly, make sure that they're not taking any specific medications that have a long half-life. The big one to be careful of something called the oral hypoglycemic, which is a sulfonylurea drug like glimepiride or glyburide or glipizide. These things have long half-life so that they can actually get repeat hypoglycemia. So in those instances, actually the preference is to take them to the hospital and have them monitored to make sure they don't get repeat hypoglycemia. So there's a precaution in the protocol that's there. If these patients are refusing, it's good to talk to online medical, because sometimes having that physician explain the rationale for the transport can sometimes make the difference in them agreeing to transport or not.
Okay, very good. You'll notice a few other changes, real minor things. We simplified the pediatric section, the dosing table. It's basically now just volume only. And there's a max now volume with, if you're giving D10 and D12.5. So take a look at those. Moving on to our cardiac changes. So the biggest change, I think, Dr. Daya, with all of these was we used to have to do CPR if it was a certain downtime or not a downtime, and we've kind of simplified that a little bit. So you want to talk about that?
Yeah, so downtime's an unreliable, and basically I think we've taken that completely out. And so don't spend time thinking about how long someone's been down. We really don't know, and the accuracy is variable. So what we really want you to do is when you arrive, confirm they're in cardiac arrest. Basically, they're not breathing, they're unconscious, and if you do a pulse check, there's no pulse. And basically you start CPR. And the idea is to do CPR for a period of time till you can get the monitor and the pads attached. How long is really unspecified. Most people think you should do it for at least a minute. If you want to do it for 2 minutes, that's okay as well. The idea is that do some CPR until you get the monitor and pads attached, and that should be your starting point for at least all of the algorithms. And if someone has already been doing CPR, then basically you can have them continue or take over while you attach your monitor or pads.
Okay. Great. Specific protocols, so acystylene and PEA, and so vasopressin has kind of gone by the wayside, or at least is
right. So
either or now kind of a medication.
So in all the protocols, basically, we used to have vasopressin as an option at number 2. At some point, you gave vasopressin as opposed to epinephrine. Vasopressin, basically, the American Heart took it out as a recommendation because the evidence really doesn't show that it's any better than epinephrine. And for simplicity's sake, they kept with epinephrine. Because we have some EMS systems locally that have been very strong advocates of vasopressin, we decided to leave it as an option here. So if you have it and your medical director wants you to give it, you can continue to use it. Realize that the current preparation is expensive, and that's another reason why, since there's no demonstrated evidence of it being better than epinephrine, at least for now, we've decided to sort of de-emphasize vasopressin as well.
So it's an either or type of medication.
And only one dose of 40 to be given in place of epinephrine, either your first or second dose of epinephrine. Okay,
and that's both in the PEA and the acystylene protocol. So the other change you'll notice too in the PED section is we removed the ET dosing for pediatrics, endotracheal dosing. So you want to talk about that a little bit?
So endotracheal dosing is totally unreliable. There's so many facets to how you give a drug endotracheally, and it's really hard. I think with pediatric cardiac arrest, I think the preference is to have an IO, which you should be able to place pretty quickly. And I think the idea is that don't use the endotracheal tube as a route for administration. It's really just unreliable. Use something that you think is more reliable, like an IV or an IO. Okay.
The VFib VTAC protocol. So ALPS completed last year. The American Heart changes came out last year. We haven't seen too many changes because of that. One of the things that did go away, though, is the mag sulfate, right?
Right. So again, what we found in the American Heart Association protocol is essentially the ALP study was not complete, so it didn't affect the guidelines of 2015. But essentially, magnesium has never been shown to be effective in ventricular fibrillation or ventricular tachycardia. So that basically has been removed as an option. So, and based on the results of the ALP study, in which we think, at least the local medical directors, that there is continued at least some evidence from our perspective that if you have persistent or recurrent VF, that you should give an antiarrhythmic. We're going to continue to stay with our two choices of amio first, and then if that's not working and you still have recurrent VF, you have a choice of going to lidocaine.
Okay. And I think the only other change that people need to be aware of is we added some language on anterior posterior placement of pads, defib pads. So if you're continually shocking the patient, you can consider repositioning pads. Mo, you want to talk about that a little bit?
Yeah, so I think one of the things that I've learned is that defibrillation, like CPR, is an art. You need to be able to put the pads on appropriately so you actually get the energy going across the heart. And so, for example, you must try to place the pad on the lateral chest so that it actually is getting to the heart along with the one that you put up front. If that's not working, then you need to make sure that a couple of things. One, that the pads are actually stuck on properly, and two, that the positions are accurate. So your shocks may be failing in part because the position of the pads is inaccurate. Second thing is that sometimes we find that just changing the vector, the direction of which the energy is going, might be preferable. So if you've given 3 shocks one way, what we're going to suggest to you is that you start thinking about maybe placing pads anterior posterior so you can actually go in a different vector. And that might sometimes help convert someone who is not responding to several shocks and antiarrhythmic drugs. It may be that there are other things that need to be done. For example, we know that these recurrent or refractory VFs, a lot of the times it's a blocked artery that needs to be opened, and that's where you have to get them to the hospital to open up the artery. But think about the fact that sometimes the direction of the vector of current that you're giving may make the difference between someone who you successfully defibrillate or not. So stick with, the folks in Bend are using the 3-2, a 3-2 rule where they go 3 shocks with one direction and then they'll switch to a different direction for the next 2 shocks. So it's just an idea that you're thinking about this when you're having that refractory shock.
Okay, good, thanks. Unstable tachycardia. So we've actually changed that just a little bit, and that's in regards to sedation medication you can give before having a cardiovertification, and that's you can now give etomidate. And so, well, you want to discuss that a little bit?
Yeah. So one of the challenging things for you in the field is, first of all, when you cardiovert someone, and cardioversion is not an easy decision to make. But once you do it, you want to make sure that the person's not awake. So if you read back into some accounts of patients' experiences during a cardioversion, if they're not completely sedate, they remember this, and it's a terrifying experience that they feel. So one of the drugs we've had for a long time that we use for RSI is etomidate. It turns out that etomidate is also an excellent sedative for cardioversion because, one, it is very short-acting, and two, it gives you almost instant amnesia, and it works very, very well. The dose that we're going to use is 0.15 milligram per kilo, so it's half the dose that you'd normally use. And etomidate is one of those total body weight drugs. It's really important that you base it on the total body weight. So remember to look at the size and basically 0.15 milligram per kilogram. And I think that this drug is preferential to use for cardioversion than is midazolam, which I don't think works well enough. The second thing is midazolam is often tricky to give in someone who's hypotensive. So, they have a pressure of 80, which is one of the reasons why you're cardioverting them, because they're in a white complex tachycardia or in a bad tachycardia of sorts. And now you can't really give them much Versed because you might drop their pressure more. You don't have to worry about that with etomidate. A couple of things to remember about etomidate is at 0.15 milligrams. Sometimes they might have a little bit of muscle twitching, but that's not something you need to worry about. It works pretty well. As soon as they go out from a mental status perspective, you can deliver your shock. And it's a very short-acting drug that basically you will see once you shock, they come back, and you do not usually need to do much in the way of respiratory support, although you should be prepared to do that in anyone you cardiovert because there's a chance that they may deteriorate further on you.
And midazolam's still in the protocol, so if you can't get an IV started, Obviously, you can't give etomidate. You still have the option to go ahead and give midazolam for some sort of sedation.
You can't give midazolam. If you give it IM, it's going to take a while to work. So again, our preference in both of these drugs is hopefully you have it. And we left this as a choice because not everybody, again, is comfortable. But in a lot of the literature that's circulating, people think that the ideal drug for cardioversion in both the ED and EMS settings is actually the use of etomidate. So, but remember, the dose is half, and that's what I hope that you'll begin to start thinking about when you have to cardiovert someone.
That's it for the cardiac updates. If you have any questions, go ahead and contact your agency EMS training officers. Thanks and have a good day.